So I know that we've seen this somewhere before.
Here.
I know. So one thing that we haven't talked about much with this acronym is that it's in the order that it's in for a particular reason. So if we think about MESIP, always the first thing we have to check for is medical problems. Once we check for medical problems, it's important next to check for problems in the environment, because we don't have to bother the patient, so to speak, about those. We can just correct the environmental problem and in some cases take care of the issue. So in a way, once we're done with medical clearance, the E part is the least intrusive thing that we can do to try to solve the problem. S is in there because of the population. Sensory is in there because of the developmentally disabled population we work with. So many of our developmentally disabled people have sensory problems, and they're not static. They don't stay the same. They change over time. That it's important to rule that out before we go on to looking at what's going on with the person's interactions. Does something need to be intervened with in that realm? And then only when we clear all of the other, the MESI possible causes, then we need to start delving into the person's psychiatric status, psychological functioning, in a way that might be argued as the most intrusive form of evaluation and intervention that we might do. So that's why not only do we like the acronym, but we put it in the order that we put it in to try to save the patient any unnecessary difficulty with treatments that might not have been required. For example, if somebody is agitated and there's an environmental factor involved, like remember the lady who used to like to look out the window at the trees, we wouldn't want to be calling a psych consult on her when all we needed to do is change how a certain vent worked in the area in which she used to like to sit and do that. And just a couple of more words about this is that sometimes more than one problem in one of these categories can lead to the production of pain symptoms. So for example, you may have a Down syndrome person who already is having digestive difficulties, gut pain and so forth, and as many Down syndrome people do as they go along in life, and then that person complains of abdominal pain to a certain degree, and then they get a stomach virus, and now the pain complaints are up. And it's an important thing to keep in mind that just because you know about somebody that there's a medical problem and it produces a given degree of pain, when you then see an increase in pain symptoms or pain complaints, it's not a safe thing to do to make the assumption that that increase is also due to the original problem that you know about. There may be a new problem that has been added on top of what you already knew about. And the same considerations apply for the other assessment areas here as well. Never a good idea to assume we know everything there is to know about what's causing symptoms in these areas when we're doing the latest round of assessment.
And what we want to pay attention to also is the level of the disability that the individual has. And just to focus on the syndrome-specific indicators of pain, there are specific issues that can happen with specific syndromes. So we pay attention to their diagnosis and the pain that they're in. But there are things we have to pay attention to in addition to that. For example, Down syndrome is going to have probably a higher cardiac and certainly a higher gastrointestinal problem that will contribute to pain experiences. You're going to have people whose cardiac functioning is going to vary, and that might cause some pain. It might cause some angina. It might cause some dizziness from time to time. Fragile X syndrome, they typically can have cardiac valve problems, mitral valve problems in particular. And when the mitral valve in the heart isn't working the way it's supposed to work, where the leads just fall into place and it has a nice rhythm going, if it's starting to flutter around and get sloppy, then the blood isn't being pushed up into the head the way it should be in a reliable source of cranial nutrients. And so the person might be a little hypoxic. Their oxygen level might be decreased a little bit. And when we get a little hypoxic, we get anxious. We look anxious. We act anxious. So that's something to pay attention to with people who have Fragile X syndrome, is that when they're looking anxious, they might actually have a mitral valve problem that's going on that's interfering with their oxygenation, and it might not reach the level of pain where they're having angina. That might be much further down the line. People who have autism spectrum disorders can have pain from different parts of their sensory inputs. They can have very painful experiences when certain fabrics touch their skin. It can feel scratchy, it can feel painful, it could be like needles and pins. People who have dementia in general can have generalized pain, and they are accompanying what's going on with their dementing process with a certain tension and suspicion about what's going on. They're bracing. They don't have a relaxed way of being. And if you've ever noticed when somebody starts to become demented, they get this kind of accusatory, glaring look to them, disapproving, like, who are you and why are you doing that breathing in and breathing out that you're doing? They have that generalized tension and suspicion, which can, of course, increase pain symptoms and contribute to them. Should we take a break?
Yeah, let's take a break.
Can we? Oh, let's just talk a little bit. Let's vamp a little bit, and we're going to take a few-minute break. Okay. So before we go back to, actually, let me talk a little bit about these. This is me, right?
That's you.
Actually, I kind of went over these. Forgot I had this slide in there. Common cardiac problems with Down syndrome, Fragile X, mitral valve prolapse, so common. Sensitivity to textures. Gee, I just went over all this. This is, remembered it pretty well. Pain is stressful. Stress worsens dementia symptoms. When you're in pain, you have one more thing to deal with, and when you have dementia, you don't really deal with things very well. So look to see if dementia symptoms are worsening. It's going to be something that you need to track in terms of having underlying pain.
Are we taking a break or will we?
Yeah, okay. Let's
take a 10-minute break. We'll be back in 10 minutes.
I'm muted, but we're still on camera.
Some of them are less disabled, and others may have a higher degree of disability. And there are some differences in the way that we would typically think about assessing for pain symptoms at different levels of disability. So one way to look at this is to divide the level of severity of disability into the categories of low or mild disability, moderate disability, and severe developmental disability, and think about how we might have to adjust our assessment strategies at each of those three different levels. Oh, that's nice. Okay. All right, so at the mild level of developmental disability, we see people who are likely to be involved with more activities, have more interactions, more modes of verbal expression, perhaps engaging in a wider array of more functional behaviors. And at the same time, we would expect when people at the mild level of disability tell us that they have pain or they're hurting or they're suffering, that these statements from somebody who's mildly disabled might have a higher likelihood of being a reliable and valid self-report. We would also be able to look at the consistency among the different areas of functioning. So we're looking at behavior, we're looking at self-report, we're looking at emotional functioning, we're looking at interactions. And we expect at a mild level of disability to see some consistency and indications of pain across these different areas if the person has a onset of a pain problem or the worsening of a pain problem. So the more consistent the indications of pain are, and the more we can rely on what we're seeing in these different channels or different areas of expression, the more we can rely on indications of pain problems as actually being reliable and valid. There actually is a pain problem there. We ask the question, are the deficits we're seeing in these different channels variable, or they're all consistent with each other? So we have a lot to look at with someone who is mildly disabled in terms of assessing for the presence of pain symptoms, a lot of areas in which we can look, and they're likely to be more consistent when there is an actual pain problem present. On the other hand, somebody who is moderately developmentally disabled, if there is a verbal expression of pain problems, it's more likely to be vocal expression, like non-word syllables, moaning, whimpering, even screaming, than actual words. Here, we think that observational scales could be more important because the person is less able to tell us about the pain they may be experiencing. And proxy reports, or reports of other staff, reports of family, friends, reports of other people on the unit, reports of co-workers and supervisors and customers might be more important for somebody who is not going to be doing as much verbal communication about pain. One thing that we need to ask ourselves when we see a person with moderate disability who's complaining of pain is we need to ask whether or not the pain in of itself has caused a reduction in functioning from a prior level, which was mildly disabled, to the current moderate disability. Because sometimes pain can impair functioning, as we've been reviewing, to the point that the level of disability can actually be seen to worsen. With somebody who is moderately disabled, we are much more into the territory of a comparison with their own baseline. What was their functioning like prior to the onset of the pain problem or the worsening of the pain problem? Remember, with mild disability, we were able to look across these different domains of functioning and look for consistency in indications of pain. But here, with moderate disability, there aren't as many domains of functioning that we can look at with as high a degree of certainty that we'd recognize indications of pain even if they were there. So here we're doing more comparison between the patient's current level of functioning and how they were doing prior to the onset or worsening of the pain problems. So with severe disability, the indications that there may be onset or worsening of pain can be quite subtle and sometimes difficult to detect. If there's any verbal communication, it's at best generally vocal, very few, if any, actual words. And so here we're faced with the task of discriminating or telling the difference between the vocalizations that are pain-related versus the vocalizations calling out single syllables and so forth, screaming, moaning, whimpering, groaning, telling the difference between those that are due to pain versus those that are a part of the patient's usual behavioral repertoire. So when faced with that task, you have to have a very good idea of what is the usual patient's vocal repertoire from the time before when they weren't in pain, and we're going to look for differences. Observational reports and scales are very important here as well. And any change in types or rates of behavior. Types of behavior include eating, drinking, sleeping, interacting, what the person does at all times of the day. Any change in those types of behavior can be an indication of pain. And what do we mean by rates of behavior? Well, let's say, for example, going back to the instance of the autistic lady who used to sit in a chair and look at the trees. She did that a lot. She did that 3 or 4 hours a day. Once the environment got less comfortable for her in that area, now she was only doing that a half an hour or an hour a day. So that is a change of a behavior rate. And what we find with pain symptoms very often is that there are changes in rates of behavior. Frequently with pain symptoms in the severely developmentally disabled, previous behaviors that occurred a lot, the person did a lot of that behavior, get less frequent, and other behaviors which are very infrequently done, very rare, can get more frequent. So changes in rates of behavior. One of the possible reasons for that is the onset or worsening of the pain problem. When we talk to other people about their observations of the developmentally disabled person that we're working with who may now be having an increased pain problem, we have to do some thinking about the usefulness of their reports. So for example, if this is someone we've talked to before, have they in the past also reported the patient to have pain when the patient had a prior episode of increased pain? Have their reports been accurate? And we have to think about, could there be any other reasons for the informant to be telling us about a high level of pain? So for example, if the, heaven forbid, the patient was in a motor vehicle accident and the informant is a relative, let's say there's an ongoing lawsuit about the motor vehicle accident, the relative has a lawsuit-based legal incentive to report lots and lots of pain. And we need to factor that into how we interpret the reports that that relative may be giving. On the other hand, if we're getting a collateral report from somebody who, you may remember before we talked about a stoic orientation from a person who doesn't really get involved much with pain symptoms and doesn't perhaps think other people should either, and that person is reporting that the developmentally disabled person that we're working with is really pretty comfortable and doing okay, we need to factor in our knowledge about that reporter's stoic orientation before we take their report at face value. So we can see, hopefully we've been seeing, and we're going to continue to see, that assessing pain in this population is complex. It requires a lot of different ways of gathering data. We have to look at the person's different areas of functioning. We need multiple sources of information. We have to spend time thinking about our favorite acronym, MESIP. And we need an ongoing process of assessment. Think of it in terms of what do we want here, a snapshot or a movie. The snapshot is an assessment that is done at one period of time and captures one moment of the patient's functioning. What we really want is multiple looks at the patient's functioning over time, because that will give us a more accurate idea of what's going on with the patient's pain symptoms, and then also we'll have an ongoing idea of the baseline. How was the patient doing then? How is the patient doing now? What are the changes that we see? Do they indicate worsening pain problems, or on the other hand, do they indicate the interventions, which we'll be talking about in our next workshop, are hopefully having some positive effect. So there are some additional issues in assessment and doing assessment for pain problems. Here are some of the ones that are rather frequently encountered. What's the patient's mood state? We're assessing a patient for pain problems, and we see that the patient has some kind of mood issue. So if the person is depressed, we know that depressed people tend to report more pain than non-depressed people. We need to factor that into our assessment. If the patient is irritable, that might not possibly be the best time to do the assessment, because the reliability of what the patient tells us and perhaps its validity is going to be reduced. When we do pain assessment and we're doing the part where we're directly interacting with the person needs to be reasonably comfortable within what's possible according to their baseline if we're going to get the best possible information from them. Now, some of the people that we work with have been in facilities for decades. They may have been in treatment for decades. And although the quality of treatment for the developmentally disabled has improved a lot over the years, unfortunately, some of the older people that we work with may have spent a long period of time in facilities where the quality of treatment was not as good and may have been treated in ways that predispose them to feel helpless about getting help that they needed, and predispose them towards just going along with whatever the staff would want. And sometimes people who have been socialized in that way are more reluctant to complain about pain. So if we know about a person that they have that kind of history in facilities, then we need to do a little extra assessment there. And we need to be looking at the person's psychiatric status. Various serious and persistent mental illnesses, when they are flared up, are going to impair the ability of the person to tell us about the pain they're in, and it may distort the observations that we do as well. So a really deteriorated psychiatric status is not a great time to be doing the pain assessment if it can be avoided. And again, the overall interactions with the person doing the assessment. Like any other activity with a patient, whether it's assessment or treatment related, it all starts with the relationship. If the person or people doing the pain assessment are doing an appropriate and good job, the first thing they're going to pay attention to is establishing comfortable communications in which the patient feels as relaxed as possible. If that isn't done, the results of the assessment are likely to be at higher risk for being inaccurate. So again, this is a point about how processes leading to pain complaints can change over time. We certainly know that medical conditions can change over time. People get better or worse. Cognitive impairment due to pain can vary over time. Cognitive impairment varies with lots of factors, including the presence or absence of pain, and for that matter, medical issues as well. So the point here is yet once again, pain assessments frequently need to be done over time and updated frequently if we're going to have an accurate picture of the patient's function.
So we're going to spend a little time talking about developmental disabilities and pain with the added feature of psychiatric symptomatology. So we're going to cover some major mental health issues, psychosis, depression, bipolar illness, dementias, and behavioral problems. The psychosis in general, and the three major components, say that again, please. The three major components for psychosis are there's hallucinations, and this isn't, the slide is a little confusing, but just ride with me here. There's hallucinations, which is a sensory experience. You can have it in any of your five senses, and it's an experience that's not real. Your brain is telling you it's real, but it is not a real, true experience. So you're going to hear things that are not there, you're going to see things that are not there, you're going to smell, taste, or touch things that are not there. And those are the hallucinatory experiences you can have. Another psychotic symptom is a delusion. And a delusion is a thought. It's something you believe in that's not verifiable, it's not a real thing. And the most common delusion is a persecutory or paranoid delusion, where you think that somebody's trying to hurt you or take something that's valuable to you, like your reputation or your sense of humor or something like that. And the third psychotic symptom is disorganization. And I'm not talking just messy desk disorganization, otherwise you would have diagnosed me a long time ago. I'm talking diagnosis of disorganization as a psychotic symptom. You can't put a sentence together. You can't communicate very well because of the disorganization, not because any selective muteness or any other issue, but the disorganization is either behavioral or verbal, and it can be quite extensive. So psychotic symptoms may mask pain symptoms because the person is so involved with what's going on psychiatrically that it's not exactly gating like what we talked about in Module 1, where all of the pain symptoms have to kind of line up behind a gate and you let one in at a time. But it's more an issue of it's taking so much cognitive power to deal with the psychotic symptom. It's so intrusive and it's right there in your thoughts and in your feelings all the time that you might not have the expression of pain symptoms in addition to it. A psychotic situation can be worsened by pain symptoms because pain removes a lot of the resilience. It removes a lot of your ability to cope. It takes up a lot of activities. So you're going to be at a disadvantage because you're psychotic. It'll interfere with communication about pain symptoms because your communications, regardless of if you're communicating verbally or behaviorally, your communications are going to probably be more focused on the psychotic experience than on a pain experience, because it's the hierarchy relegates that to a lower level. It'll decrease your ability to cope with pain when you have psychotic symptoms because it is more intrusive and it's absorbing a lot of your coping mechanisms to deal with the psychotic symptoms. And then, of course, disorganized cognitive processes can cause an insensitivity or a hypersensitivity to pain. And what I mean by that is that we have a certain part of our brain called executive functioning, and it functions like an executive. It helps us to organize information. So as data is coming in and your experiences, you're able to say, well, I don't need to pay attention to that. So you, for example, you'll have the lights in the room you are in, the clothing on your body if you happen to be wearing clothes, the furniture in your environment, other people in your environment, movements out in the hall. All of these things we can kind of relegate to a lower level of attention because our executive functioning has helped us to stratify those data points. But when you have a psychotic symptom, regardless of the reason for the psychotic symptom, your executive functioning isn't going to work very well. Sometimes it only works at 7% of its capacity, or on a good day we're mostly in the 90% range. So you're not going to be able to distinguish and have discrete experiences about data. So you're going to be experiencing the lights flickering and sounds and people breathing and writing and the clothes on your body and the furniture and a truck going by outside. All of these things are going to be crashing in on your awareness, and your cognitive processes are going to be all jammed up because of those experiences. And it can be an insensitivity because you're overwhelmed with these cognitive messages. So sometimes when you see people who are psychotic and they're just doing this, it looks like they're out of it, but in fact they're way too into it. They've been overwhelmed with data points and they were not able to stratify it. And then you have people who are hypersensitive, so something very minor like a tag on a shirt or something will make them very, very uncomfortable and they'll keep focusing on it. So you're going to have these insensitivities or hypersensitivities, a distorted cognitive process going on while the person is experiencing their pain. So we actually had somebody who had a pretty bad accident. They were impaled. Their foot was impaled on something, but they were having this cognitive process go on, a psychotic process, and they were insensitive to it. And they were walking on it and hardly noticing it because of that level of insensitivity to the pain. On the other hand, we had somebody who was having a lot of trouble and a lot of pain breathing in and breathing out just on normal breath. There was no flu, there was no upper respiratory infection, but the person was having such a difficult, painful experience with breathing, and that came as a result of the executive functioning being distorted.
So let's talk about affective disorder, major depression, and bipolar illness. There we go. And then we have illustrations of what look like a cutaway of the planet Earth with the magma in the middle and the iron core, but that's for another presentation. So how do we assess properly for pain symptoms in a person who has developmental disability and also either major depression or bipolar illness? Let's start with depression first. And one of the reasons we're starting with depression first is that when there is a psychiatric problem with somebody who is developmentally disabled, it tends to be the most common one. So the most common psychiatric problem in people who are developmentally disabled is depression. And when we think about depression in the developmentally disabled, but this is true of people in general, we can think of two main types of depression. There's, on the one hand, a kind of a sluggish or exhausted depression where people are withdrawn and they're undermotivated, they're not very active, they don't do much, they don't feel like doing much, they sleep a lot, just really sluggish and under-participative. The other type of depression is sometimes referred to as agitated depression. Here, a person, when they're depressed, may also be anxious, agitated, irritable, and they may have trouble focusing, and they may be restless, and just out of sorts in general. Depression affects all facets of a person's functioning. Activities of daily living, working, social life, response to treatment, and response to pain management interventions as well. So what do we look for in a developmentally disabled person who may also be having a pain problem, but we suspect that there may be depression? How do developmentally disabled people communicate depression? Sometimes the first things that are seen are nonverbal or even non-vocal. Observe changes in behavior. If it's a sluggish depression, we're going to see low energy, less participation, less effectiveness in interacting, more sleeping. We may see sadness, including crying. Often we would see withdrawal from social interactions. We can see sometimes poor eating, where the person actually starts to lose weight, but as the other ultimately awesome Dr. Triggerboff mentioned, we sometimes can see weight gain, as some people who are depressed gravitate towards comfort foods. It's also true that some people who watch football games gravitate towards comfort foods, but that's another story.
The presentation.
Yes. We can sometimes see with depression disturbed sleep. With a sluggish depression, we would certainly tend to see increased sleep. Right? A person might sleep, whereas before 5 or 6 or 8 hours a night, now they're sleeping 10, 14, or 16 hours. With an agitated depression, you might be more likely to see irritability or anxiety. And we always have to be alert with depression for any indications of lethal behavior, either self-lethality, suicidal potential, suicidal statements, plans, heaven forbid, acts. And we also need to be on the alert for lethality directed towards other people, particularly with an agitated depression. One can sometimes see hostile intent towards others, even homicidal plans, and heaven forbid, occasionally homicidal behavior. And in addition to keeping all of that in mind when assessing for depression in a developmentally disabled person, we need to watch out for a symptom called, technical term, mood congruent psychosis, now in English. Sometimes when people get very depressed, they develop psychotic symptoms that go along in content with the severe depression. So they might start hearing voices, and generally the voices would be saying something negative to them, like you're no good, or everything is your fault, or they might have even visual hallucinations where they're seeing horrible or terrible things, again going along with the emotional tone of the depression. So when we're working with a developmentally disabled person who we suspect has a pain problem, but we also think that they may be depressed, we have to keep in mind that the depression symptoms may mask pain symptoms, because there's a lot of similarity between the symptoms of depression and the symptoms a person manifests when they're in chronic pain. Withdrawal or undermotivation, for example, can come from pain, and or it can come from depression, or it can come from both. A lot of sluggishness can come from depression, but it can also come from not feeling like moving because one is in a lot of pain. So we understand that depression may mask pain symptoms. Depression also makes a person more vulnerable to pain symptoms. And it works the other way around too, that pain increases the likelihood that a person may become depressed. And depression increases the intensity of pain symptoms. So pain and depression can positively reinforce each other in a kind of a accelerating vicious cycle. So when we're assessing a person for pain who is developmentally disabled and also maybe having some symptoms of depression, what we end up having to do is to do a full assessment, both for the presence of depression and for the presence of pain. And as part of the assessment process, we need to try to understand what is the relationship in this particular person between pain and depression? Are they both present? Is the pain resulting in symptoms of depression, or is the depression sensitizing the person to what was before less of a pain problem and is now more of a pain problem because of the increased sensitivity? So there's that to figure out, and the way to start doing it is to do a complete assessment for depression and then also a complete assessment for pain.
So bipolar illness, which happens 2 to 3 times greater in people who have developmental disabilities than in the general population, and bipolar illness happens about 2 to 3%. So we're talking anywhere from 4 to 9% of people who have developmental disabilities are going to have bipolar illness. A lot of people. The bipolar depression, and bipolar has different characteristics. You can have the mania, which is the heightened mood, hypomania, which is a slightly heightened mood, mania, which is a fully heightened mood, and then the depressive aspect. Sometimes bipolar depression can require different treatment than just major depression by itself, and sometimes that's how we diagnose it, is that somebody has depressive symptoms and they have all of the problems that can go along with the depressive episode, and you're giving them an antidepressant and it's not working. And you check and make sure that they're not drinking alcohol, which is a depressant, so you have no confounding features there. So you know for a fact that they're having depressive symptoms, but an antidepressant isn't working. And if you add a mood stabilizer and it starts to work, then you know they're bipolar, and they're just in the depressive phase of bipolar illness. So the symptom topography and the disease subtype can develop and change over time. As a matter of fact, most people who have bipolar illness as a diagnosis have 3 different diagnoses before they receive the diagnosis of bipolar illness, because their symptoms are morphing and changing, especially as young adults. You have 25-year-old, 30-year-old people with developmental disabilities whose symptoms look like something else, like attention deficit hyperactivity disorder, like some personality disorder types, and like depression. So ultimately they will end up with the diagnosis of bipolar illness. So you need to track what's going on with the symptoms and make adjustments of the interventions. So these are the subtypes of bipolar illness. Type 1 is manic and depressed episodes. So you have full mania and full depression. But that doesn't mean you get mania, depression, and that kind of a distribution. The mood disorder can have, you can have a manic episode when you're 19 years old, and then you have depression, 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 and you have like 40 episodes of depression over the next 15 years, and you don't have another manic episode. That's type 1. Type 2 is where you have hypomanic, or you don't have any mania of symptoms whatsoever, and you have depression. Lots of depression. And mostly the type 2s are the ones who get misdiagnosed, or the diagnosis is much more difficult to arrive at because they are just demonstrating depressive symptoms. It makes it more difficult. Then there's something called the rapid cyclers, and those are people who will have 4 digressions from a normal mood in a year. It doesn't matter whether they're mania or depressive episodes. If they're non-normal mood episodes and there's more than 4 in a year, then they're rapid cyclers. And rapid cyclers are very difficult to treat. You have to be right on top of what's going on with them. And as can happen with depression, it also happens with mania. Psychotic symptoms can be a part of it, and they're mood congruent. So if you think you're fabulous and that's what mania is, you're smarter, you're sexier, you're better than everybody else, and certainly better than all you maggots, and it has this kind of taint to it that is excessive and over the top. And if they have a psychotic symptom, it's probably that they're the governor, or they're a god, or they have some kind of psychotic delusion around that. And these are the manic symptoms. The abbreviation is dig fast. Digging, digging, digging fast. And what it stands for is distract. The D is for distractibility, so the person is very easily distracted. There's insomnia, so basically they can be up for 2 or 3 days in a row, they're not sleeping at all, and they are not tired. G is for grandiosity. Everything is overinflated and over the top in terms of their abilities and who they are and whether they're famous or rich or powerful. The app is flight of ideas. The ideas come in so fast into their brain that it's very difficult to organize them. The A is for agitation, so they're moving around a lot, and they're, because they're distractible and they're not sleeping and they're having all these grandiose ideas coming into their head very, very quickly, they tend to be agitated. Their speech is pressured and high volume. We liken it to a fire hose, that the words are coming out way, 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 way too fast, way too much to keep track of, way too fast, something like the way I'm speaking now. And this last T, the T is for thoughtlessness. It's really impulsivity. The dig fasti doesn't make any sense. So they don't think before they do something because, remember, they're just not able to stop and process information because everything's coming into their brain so very quickly. So they do things that are very dangerous. And a lot of times people who have manic symptoms are much more likely to hurt themselves by accident, not by design. They're not trying to hurt themselves or try to kill themselves. But it can look to other people as if they're doing things like, oh, I have such fabulous balance that I can dance on the railing of the balcony of the apartment. But to the people down by the pool where the person falls, it looks like they jumped. So manic symptoms usually have a high level of activity, and that high level of activity can distract from pain symptoms. So keep in mind that people are very organized about, even people with major developmental disabilities, and if they realize that the medication kind of keeps their symptoms under control, and they don't want those symptoms to be under control, then they're not going to take their medication, or they're going to cheat their medication in some way. So you might end up with somebody who is actually not taking their mood stabilizer because the mania will help them not feel the pain so much. Mania can mask the pain experiences. It certainly increases the irritability and agitation that's normally present when somebody is manic. So they're going to be even more irritable and more agitated. And you might not know why that's going on. You might just think, well, gee, that symptom is getting a little worse. It's going to decrease the intensity of the pain because their brain is very occupied with the mania. And it's going to decrease the ability to cope with pain because they're not coping very well at all. So they're not going to be able to recognize the pain, they're not going to be able to process the pain, and they're not going to be able to cope with the pain. Depressive symptoms are exactly the same as in major depressive disorder. The depression can mask the pain symptoms because a lot of the symptoms, as the fabulous Dr. Trigoboff said, look like they could be pain symptoms or they could be depressive symptoms, and we have to be able to pull that out. They increase the incidence of pain experiences because of the way we're wired as human beings. We actually will feel pain more acutely when we're depressed, and when we're in pain, we're more likely to get depressed. So those two things start to fall together. There's an increase in the intensity of the pain, and there's a decrease in the ability to cope with the pain.
So sometimes we're working with developmentally disabled people who may have had the onset of Alzheimer's dementia and possibly also the onset of a pain problem. And assessing people with dementia for pain can pose its own set of issues. We could divide Alzheimer's dementia for the purposes of pain assessment, let's say, into mild, moderate, and severe. So in mild Alzheimer's dementia, we wouldn't necessarily expect to see a whole lot of agitation or frequent verbal outbursts or sustained yelling or trouble in the dining room, mealtime issues, irritability and agitation, or physical acting out. So because we don't expect to see that with mild dementia, if we have a developmentally disabled person, let's say somebody with Down syndrome, who has had Alzheimer's dementia onset, but is still in the mildly impaired range of the dementia, and we now start seeing a notable increase in agitation, verbal outbursts or sustained yelling, or trouble in the dining room, mealtime issues, or acting out, one of the things that we should suspect there as a possibility is that this is the onset or worsening of a pain problem. Because even mildly demented patients who are developmentally disabled will tend to manifest these symptoms when they have a significant pain or pain increase. Now, on the other hand, with moderate or severe Alzheimer's dementia, developmentally disabled patient will be agitated at times anyway, is going to have verbal outbursts anyway, will be likely to have mealtime issues even when they're not in pain, and there are going to be episodes of physical acting out anyway. So in this case, where the person has moderate or severe dementia, what we're looking for, again, is change in the frequency, rates, intensity, duration of all of these symptoms. So the person had a certain level of agitation, but now they're even more agitated. Or before they had 2 or 3 outbursts of yelling a day, and now they've got 12. Or it used to be that if you sat them at a quiet table out of the main area of traffic, they did sort of okay with mealtime issues, but now they just can't tolerate the dining room at all. Or previously, once in a great while, they might look a bit aggressive, and now there are assaults. With a moderately or severely impaired dementia patient with developmental disability, these are potential signs, these changes in behavior of the onset or worsening of a pain problem. And so we can come at this from 2 directions. We have somebody that is moderately or severely impaired with Alzheimer's dementia and developmental disability. If we know that person is going for a medical procedure, or heaven forbid they've had some kind of accident or injury, we know to expect that it's likely that there'll be more agitation, verbal outbursts, mealtime issues, and physically acting out. And we need to plan for that. We need to plan for that in our interventions and management. And from the other direction, if we see that a person is experiencing these symptoms exacerbated in a sudden way, we need to consider pain as a possible explanation.
So many medications that treat dementia, they're called acetylcholinesterase inhibitors. They're also called cholinesterase inhibitors. And not to go into the pharmacology too much, because we'll actually be doing that in the pharmacology module later on, there are common gastrointestinal side effects. And a side effect, a major side effect, is nausea and pain. So the medication we're giving for dementia can cause pain when the person already has a pain situation. So you have to be able to acknowledge when the pain is occurring that is a side effect of the medication versus when it's got the pain situation in place. There are hazards in addition to benefits for the acetylcholinesterase inhibitor medications. It doesn't delay the disease process whatsoever. We haven't discovered that yet, although they're working on it. What it does is it increases the availability of choline in our brains, and choline helps us with memory. So it will help that particular neurotransmitter be a little bit more effective for us while the disease continues to degrade the effectiveness of your memory. That's all the acetylcholinesterase inhibitors do, is they delay the full effect of the dementing process of Alzheimer's dementia. The major hazard is GI bleed. So you might have a gastrointestinal bleed go on. And sometimes it's kind of hard to tell that. It hurts, but they can have pain without a bleed. So there has to be a fairly good assessment on that. Some problems unique to the developmentally disabled population are the environmental impacts. The people with DD are sensitive to the ambient environment, temperature, light, vibration, absorption of sound. So some places, especially if you have a lot of tile and formica, things like that, the decibel level bounces around and it can be very confusing. So that ambient environment can have a lot of features to it that can be a problem. There are changes to the environment. We had somebody who was actually doing quite well with a chronic pain set of symptoms, and they decided to upgrade the paint job in the place, which this residence, this group home he was living in, had this revolting green paint. And it was, you know, that was the thing in the 60s or 70s when they built this particular group home. And they decided to change it, and they upgraded it, and they painted this very nice beige color wall. He didn't handle that very well at all. It was very disruptive to him. He did not like it, and it bothered him. It like, physically bothered him. There's health impacts. People with developmental disabilities have a great number of comorbid conditions, and all of those health impacts as well as the functional impacts will make a difference in what's going on. Substance abuse issues. We can do an entire module. We could probably do a whole set of modules on substance abuse issues of people with developmental disabilities. It's a huge problem, and it's only recently been acknowledged, and only to a small degree in the literature. There's long-standing substance use and substance abuse issues that happen with people who have developmental disabilities. Frequently what happens is that people might be self-medicating. So if they have spasticity, they might use some marijuana or some alcohol, whatever they can easily get a hold of to make themselves feel more comfortable. But if you have pain issues, self-medicating for pain is a very common issue. And recently, we have seen these commercials where people are going into the medicine cabinet and going to take their medication. And when they close the medicine cabinet, you see a teenager or a young person who's taking these medications. And it says here you should be careful with your medication. This also is true in group home settings or when people live with family members, is that they might self-medicate with whatever they can get a hold of, whatever they can barter for, whatever they can just take from each other. There's a lot of misunderstandings and misconceptions about substance abuse issues of people with developmental disabilities. So that's kind of a new opening that needs to be explored more thoroughly. And there's also inadvertent substance abuse issues where people who have a developmental disability and maybe even their family members just don't understand the impact that substances can have. A beer, one beer that doesn't have a high alcohol content at all is still alcohol, and it can have a terrible impact on what's going on with that person with their developmental disability and with their pain and with their other medications that they're taking for their comorbid conditions. Or sometimes they just read the directions wrong or they can't read at all, functionally illiterate. So they'll take something like a cold medication that is alcohol-based and they don't realize that they're taking 4, 5, 6 times what the dose should be because it's liquid and they just slug it back. Depression is a very pervasive problem in our society in general. It is called the common cold of mental illness because lots of people, 1 out of 4 women and 1 out of 6 men, will have a depressive episode at some time in their lives. And that rate is higher for people who have developmental disability. Alcohol is a depressant. Alcohol from any source. So wine coolers, beer, hard ciders, something else. If you can buy it in a grocery store, people think it's not alcohol. And so frequently people who have developmental disabilities will stop and buy something that looks like it's lemonade when really it has alcohol in it, and alcohol is a depressant. It's depressing psychologically, we know. If you've ever seen a weepy drunk, you know how it can really depress somebody, but also it's physiologically depressing. So it will reduce somebody's capability to cope because they are physiologically and psychiatrically depressed. So we don't want to have any alcohol added to that. Self-medicating to treat a depression is very common. People will say, well, gee, I need to perk myself up. And if somebody's had a bad day, they say, well, it's well-deserved because I had a tough day, so I'm going to have this alcohol. Well, that's translated into the developmentally disabled population. They also might think that it's a treat and it's somehow a coping mechanism. And if they're feeling like they're in a funk and they're really not doing very well, they might have a drink to try to address that or ameliorate their situation, and it's just going to make it worse. And of course, it'll make the pain worse. There are complications that arise from combining substance abuse with developmental disability. Top of the list is their psychiatric symptoms are going to get worse. They're either going to develop psychiatric symptoms that they didn't have before, like depression, or they're going to have worsened symptoms. They're not going to be able to be compliant with their medications, and that's all of their medications. So if they have a seizure disorder, they're not going to take their meds on time, or it's going to be a distorted absorption process because there's the substance is going to delay it in some way. there's an increased need for emergency care services and an increased use of emergency care services because they're drunk or high. So it's not easy to think, gee, I have to go to this doctor's appointment or I have to take this medicine the way I'm supposed to when you're drunk or high. And any medication is not going to work well if it has a substance on board. Alcohol, marijuana, opioids, anything will change it. Opioids have a particular problem with people who have developmental disabilities because opioids will slow down the peristalsis process and they're going to have constipation, which is just doubles up, and they can get constipated and then impacted, and then they might have a bowel obstruction. You have an unstable clinical course with any of their diagnoses, psychiatric or medical. They are not going to be healthy people. The substance is going to throw everything off track. They're going to end up going to the hospital more often. They're going to have chronic threats to health because these substances that they're using are debilitating, more debilitating than they are for the general population, and you know what it does to the general population. It eats away at them. And there's an increased risk of tardive dyskinesia, which is a movement disorder that can happen as a side effect of some psychiatric medication. There's behavioral problems because when you're drunk or high, you're going to be doing things that most people would arrest you for. So you're going to be yelling at somebody, you're going to be shoplifting because you didn't realize you didn't pay for something, you're going to fall asleep on the bus and you're not going to be able to, you're going to miss your spot and miss your stop. Sometimes the substance abuse can be so intense that the person thinks about or actually attempts to kill themselves. They can lose their home because they're kicked out, because they're drunk or high and the facility or the group home or their family is not going to tolerate it. And of course, when you're drunk or high, you're more likely to be violent, especially if you have pain issues. Pain can be treated by substance abuse. It's a very ineffective and problematic treatment regimen, but that is what people do. And DD recipients may seek pain medications as a substitute for whatever they were using. So let's say they were drinking and somehow their alcohol concept, or their alcohol access was decreased, or they were smoking marijuana and they no longer have access to the marijuana or they're out. Well, then they're going to complain about pain because they're going to want some of that experience again. They become more easily addicted to analgesics because of limited cognitive abilities. Addiction becomes much more common. And they have more pain complaints because they, when there's more pain complaints, that tells you that there's an increased risk of abuse and the relapse to the abuse. So this is a unique population, and they have to have treatment for these various problems at a level that acknowledges wherever the skill level is for that individual consumer. It acknowledges that they do have some durable deficits, that things they're going to be weak in some areas, and those are the areas that you're always trying to strengthen, but you're not going to be able to do a whole lot because you're swimming upstream against pain, and it's going to interfere with their progress. We need to incorporate behavioral interventions. We're big on non-pharmacological interventions for pain management, which we'll talk about in the third module. You have to arrange care in a logical manner that takes advantage of the times when the pain seems to be less, when their resilience seems to be up, and they have some rest and some recuperation that can be taken advantage of. And also you need to arrange for the care in a way that allows for flexibility.